So we were talking about the algorithm for PPH. After resuscitation and catheterization of bladder and the first thing was to call for help, unless you're a senior and you're the only help that is available. So after calling for help and then vitally stabilizing the patient and catheterizing the bladder, what we are going to do was we did the bimanual tamponade. Okay, and then if it fails, then we are going to go for uterotonics. And as I said before, the first one would be oxytocin. And what was the dose? 20 units in 500 ml. Okay. Now we have to, if in uterotonics, usually if a certain dose does not work, we gradually increase the dose and we then switch the drug, and we wait for its effect. But since this is an emergency, we are going to look for an immediate effect. Okay. So no immediate effect, switch. Okay, whenever there is no immediate effect, you have to switch to the next drug. You're not going to wait for its effect. Okay, so basically if this does not work, then we're gonna go for we can go for methergin. As I said, it's pretty dangerous if the female has pre-eclampsia or eclampsia, or if she has a peripheral vascular disease or a heart disease. Then in that case, methergin is contraindicated. Okay, remember these cardiovascular contraindications. Okay, if this does not work, then we're going to go for prostaglandin E1, which is misoprostol. Okay, and another option is, if this does not work, we also have carboprost. We can also use that, which is F2 alpha analog. Both of these are prostaglandins. Okay, now this is an analog. Now, basically, so we had the options of 4 uterotonics. Which ones were those? First was oxytocin, then we had methergin, then, the order is not specific. The first one always has to be oxytocin. Then you can use either methergin, misoprostol, or carboprostol. So let's say that the uterotonics have also not worked. So bimanual tamponade did not work. We went for uterotonics, did not work. Now what? Now, this step can be done in the beginning or any time. If the bleeding is not controlled, you have to recheck whether there is any retained tissue. Just look at the placenta once again, and just for your surety that all the cotyledons are present, whole surface is present, no, it is delivered, entirely delivered, no tissue is left. And also look for any laceration. The other T's, na, just because our main concern was stone. Okay, but these two things are not working, so maybe the cause is not a tone, and this step can be done in the beginning to confirm the cause. And you have to look at the placenta and any lacerations. Okay, okay, now after uterotonics they have not worked. Now we're going to go for a balloon tamponade. Okay, the first thing that we did was a bimanual tamponade, and then a balloon tamponade, and then in between we used uterotonics. Okay, if you want to remember the algorithm, then remember tamponade, and in between uterotonics, bimanual tamponade, uterotonics, and balloon tamponade. So this balloon tamponade, it uses a Bakri balloon. The principle is still the same. We are going to inflate a balloon which is going to exert pressure from the inside, and it is going to compress the myometrium and hence the blood vessels which are supplying it, so the blood loss is going to be decreased. Now we have a Bakri balloon, and basically it is not freely available. We can also use a condom catheter, in which we take a Foley's catheter and then we inflate its bulb, and then condom is tied to it and filled with saline. And over here we fill this Bakri balloon with 500 ml saline normal. Let me show you a picture. Now what we are concerned after this is basically surgical methods. We did 2 methods of tamponade and uterotonics. Now for surgical methods, we have options of compression sutures. Okay, and we can also ligate the artery. Okay, stepwise devascularization. So which one of these are you going to choose? Basically, this is if the patient is hemodynamically unstable. This is also a question. What are you going to prefer in surgical methods? If the patient is hemodynamically unstable, you are going to prefer these compression sutures. Okay. So let me show you these compression sutures. Some screenshots from the internet. Okay. So these are of several types. Okay. We have B-Lynch sutures. This is the most commonly used. At least know this one. Okay. And then we also have the Heyman. I don't know how to pronounce this. Let me write over. Heyman sutures. And then we also have the Cho square sutures. Like Co square, or I don't know how to pronounce this. Okay. So this is a B-Lynch suture. You can see this is applied across the fundus. Another one, like across the uterus it is applied, and see how it compresses it when you close it. See how it causes compression of the uterus. Okay. Another one. Okay. This is a co-square, or I don't know how to pronounce it, co-square suture. As you can see, this is square, right, in the square like this. You can see. So four or more than like four sutures are applied in the form of a square. When were we going to choose this? When the patient is hemodynamically unstable. When we are choosing the surgical options, we are going to prefer this over ligation in unstable patient. Now we have devascularization procedures. Ligation. So for ligation, we're going to go stepwise. Okay, the first artery is going to be bilateral uterine artery. Okay, still no effect. Then you're going to ligate the internal iliac artery, anterior branch. Never ligate the posterior branch. Always remember that. Okay, anterior branch. Then you can also go for bilateral ovarian artery. So this is known as stepwise. This is certain, this order you are supposed to follow. Okay, uterine artery, still no effect. Then internal iliac, bilateral, anterior division, remember this, and then bilateral ovarian, if still no effect. Okay. Now we also have an additional, okay, now this was it. Now still the patient's bleeding is not being controlled, then no, it's very worrisome, because a lot of time has passed. You have tried two sorts of tamponades, uterotonics, you have tried these surgical procedures. Now just remove the uterus, okay? You don't have any other choice. You have to save the patient's life. So just do this emergency hysterectomy. Or you also have this pack, which is known as a parachute pack. What is done is that this parachute pack is placed inside and it is left there, and then it is removed along a local point in time. Usually packing with gauze is not recommended because it can cause infection. So we go for a parachute pack. It is also known as a pelvic pressure pack. This is also an option that you can use. Okay. See, this is the parachute pack. It's like really large and it is placed inside the uterus, and over here you can see it just fills up the whole area. Okay, this is it. This and this. Okay, so let's just look at the steps again. The first three things were general but very important. Calling for help. Don't mind my writing, okay. Calling for help, and then we went for resuscitation, and then very important, empty the bladder. Empty it, okay. Catheterize it, very important. 1 star, okay. And then you applied a tamponade, that was bimanual, and then you went for uterotonics, okay. And then you applied a tamponade, which was by a balloon, okay. And the specific name for that balloon was Bakri balloon, okay. And then after these main things, you went for these surgical procedures. And in surgical procedures, what did we have? In surgical procedures, we had the option of compression sutures, and we have the option of stepwise devascularization, in which I have already discussed the order of the vessels in which they are to be ligated step by step. If the first ligation is not useful, only then ligate the second artery. Otherwise, it's enough. And then sutures I already showed you. This is preferred Over this is preferred when the patient is hemodynamically unstable. Okay, and then if all these things don't work, we're gonna go for hysterectomy, and we also have the option of parachute packing.